Hello, everyone, and welcome to this webinar. We will get started in just a few minutes. Thank you. Hello, everyone. Thank you for joining. We're going to start in about 2 minutes. Thank you. Hello, everyone, and welcome to this AIDSview webinar. We're going to get started in just a minute. I wanted to make a note that the chat section will be closed, but if you have any questions throughout the presentation, we will be doing a panel discussion / Q&A at the end. So feel free to submit your questions in the Q&A box, and we will get to as many as we can. So now I am going to turn it over to Dr. Patrick Sullivan. Thank you.
Good afternoon, and thanks for joining us. My name is Patrick Sullivan. I'm the principal scientist at AIDSview and a professor in the Department of Epidemiology at the Rowan School of Public Health at Emory University in Atlanta. And really excited to share with you today some new data that we have on AIDSview and some of the insights we've generated from it. Today, I'll be presenting a little bit about this new data, what it is, some findings that we shared recently at the IAS conference in Montreal. And that'll be followed by a panel discussion. And the panel will be moderated by my colleague, Dr. Aaron Siegler from Emory University, and will include two just preeminent scientists, Amanda Castell from the Department of Epidemiology at the Milken Institute School of Public Health at George Washington University, and an AIDSview scientist, and Dawn Smith from the Division of HIV/AIDS Prevention at the Centers for Disease Control and Prevention. So thank you for joining us. Briefly, I want to give you a little bit of background about the PrEP data and what we're doing with it on AIDSview. I'm going to talk some about a presentation that I made at IAS a couple of weeks ago and some new findings around PrEP equity. Then I'll talk some about the PrEP resources on AIDSview, and we'll have a panel discussion and time for some questions. So let's start with a little bit of background about the PrEP use data that we used in this analysis. So most of you probably know what AIDSview is, but for those who don't, I just want to give a brief introduction to the platform. Sometimes it's hard to believe, but it's now been since 2010, 12 years that AIDSview has been operating as a partnership between Gilead Sciences and Emory University. And our goal has always been to visualize and disseminate data about the US HIV epidemic, to allow people to see the data. And I think sometimes when we see things as opposed to looking at numbers, we may develop some different insights. And so that makes this the perfect place to house our new data on PrEP use by race and ethnicity. Our mission at AIDSview is to make data widely available, easily accessible, and locally relevant to increase awareness and inform public health decision-making. AIDSview has a broad user base, including public health officials, policymakers, advocates, researchers, people impacted by HIV, and the general public. Just as a reminder, when we started in 2010, the most granular level of data that we had available were AIDS diagnosis rates at the state level, that map on the far left. And in the 12 years that we've been running AIDSview, we've made it our mission always to push to add more data, to increase the granularity of our data. We know that all prevention is local. And so if we start with state level data, we want to ask, can we get to county level? If we start with county level, we want to ask if we can get to zip code level. And the further down we can get with these data while protecting confidentiality and maintaining the integrity of the data, the more useful those data are to inform prevention efforts. So over time, as you can see on the map, we've added new kinds of data, we've added new diagnoses, we've added PrEP data, care continuum data, and we've also gotten more granular. Down to the zip code level in cities, for example. So PrEP was approved for HIV prevention in 2012, and it's never been quite clear how much PrEP we need to have in use, but models suggest, for example, that if we got 40% PrEP use among men who have sex with men who had a PrEP indication, that would result in about a 33% reduction in HIV incidence. Even with that kind of goal, through 2017, our PrEP uptake was really falling well short of that goal. But measuring PrEP uptake isn't as simple as looking at a proportion of people with indications who need to be using it. And this is because we know that not everybody's risk for HIV is the same. In the United States, Black and Hispanic Latinx people have higher rates of new HIV diagnoses than white non-Hispanic people. So it makes sense that those groups should be using PrEP at higher rates than should white non-Hispanic people in the US. Similarly, people in the US South have higher rates of new HIV diagnoses compared to people in other regions. If we start to take a health equity view of this, we would say that we want the access to and use of prevention interventions to be proportional to the risk of HIV among individuals and communities. And that's really the move that we're trying to make with what I'm going to share with you today. So if we think about an equality versus equity approach to PrEP, equality would be the situation on the right, where we say we want to treat everyone equally, and so we're going to give everybody a one step up. And as you can see in the figure that's here, you can see the flaw in that logic, and that is that not everybody starts at the same place. In our analogy here, the three people who are trying to see the ball game over the fence start with different needs to be able to reach that goal. And so equality says give everybody one step up. Equity says let's rearrange our resources so that everybody meets that level of opportunity. And some people are going to need more than others. Some communities are going to need more than others. And so equity recognizes that each person has different circumstances to start and allocates the resources and opportunities that that person, that community needs to reach an equitable outcome. And that's what we're striving to quantify. So now I'm going to talk specifically about the IAS analysis and the findings. So first, I want to briefly discuss the methods we use and some of the limitations of the data. So here we're using commercial pharmacy data to enumerate PrEP users by race and census region in the US from 2012 to 2021. And one thing that we've added compared to previous AIDSview presentations is data on race ethnicity. So data on race ethnicity were available for nearly 125,000 PrEP users, so a little more than a third. That's a limitation that I'll come back to. We estimated the total PrEP users by race each year. And to do that, we had to make an assumption that the racial distribution was the same in the PrEP users with missing race data as in those with reported race data. Again, important limitation, and I will come back to it. The metric we're using here is the PrEP to need ratio. This was developed by my colleague, Aaron Siegler, who you'll hear more from a little bit later at Emory. And it's a measure of PrEP equity. And it's that idea that I tried to introduce before, which is I said, like, we'd like for the access to and utilization of PrEP to be in proportion to the risk of PrEP in a group of individuals or in a community. And PrEP to need just defines that as the number of PrEP users in a group, that's the numerator, divided by the number of new diagnoses in that group in the same year. So as we are going to share the data today, the PrEP to need ratio for 2020 and 2021 is going to have a denominator that's 2019 diagnoses, because 2019 diagnoses were the most current data available at the time of the analysis. The important thing is that this ratio is really used to describe the distribution of PrEP prescriptions normed to the relative epidemic need. And so when this number is higher, that represents sort of more use relative to need. We talk about PrEP equity. PrEP equity would mean that if we look at different groups, different regions, different sexes, different races, that the PrEP to need ratios would be equal if we're getting equitable PrEP use. So let's take a look and see how that plays out by region and by race in the US. All right, I want to orient you to this slide, and then I'll make 3 points about it. First, notice that there are 4 panels in the slide, one for each of the US regions, with the Midwest in the upper left, South in the lower right. And then notice within each region, there are 3 colored lines. These represent the PrEP to need ratios, these measures of equitable PrEP use in different racial ethnic groups. So the purple lines are the PrEP to need ratio for white residents in those regions. The yellow lines are PrEP to need ratios for the Hispanic residents in those regions, and the red lines are the PrEP to need ratios for the Black residents in those regions. So I'd like to make 3 points. First is that in all years, the overall PrEP to need ratio is highest in the Northeast. I'm just pointing here to the line for white residents in the Northeast. But these are the overall regional PrEP to need ratio is the highest in the Northeast. And in all years, the PrEP to need ratio is the lowest in the US South. Keep in mind that the denominator for this PrEP to need ratio is the number of new diagnoses, and we know that the sort of rate of new HIV diagnoses is quite high in the South. The second point I want to make is that within each of the 4 panels, look at the relationship between the PrEP to need ratios by race ethnicity. So keep in mind what I said before, which is PrEP equity by race, for example, would look like the purple, the yellow, and the red lines all lying on top of each other. That would say the PrEP use in the West, in this case, is equitable in terms of where the new HIV infections are occurring in that region. So we would like to see these lines increasing, but also lying on top of each other. Instead, what we find in all 3 regions is that the PrEP to need ratio is highest for the white residents in those regions, is intermediate for the Hispanic residents in those regions, and is lowest for the Black residents in those regions. And that sort of plays out across all 4 regions. The last point that I want to make is about the extent of the inequity. So if we look here at about 2016 in the Northeast, the height of this red arrow is sort of the distance or the inequity between the PrEP use in the Black and Hispanic residents in the Northeast, that's the red and yellow lines, and the white residents in the Northeast, which is the white line. So think of that distance, the height of that red arrow, as being the amount of inequity by race in the region. And as we look from 2016 to 2019 and on to 2021, it's pretty striking that the extent of the inequity is actually growing. That even as we're aware of this problem, even as we're talking about how to get PrEP to the people that need it most, what's actually happening in all 4 regions is that the extent of the inequity is actually widening. And we can sort of look at this, broken down by region, but really, even if you get more granular than region, you can see this same pattern where the highest PrEP to need ratio, represented by the darkest shade of green, is observed in the states in the South among white residents. The lowest relative equitable use is among Black residents, and Hispanic residents are intermediate. This plays out across regions. So on AIDSview, we also like to sort of highlight and illustrate some data insights that come from these data, and these are put up as infographics, shareable infographics on the website. If any of these really resonates with you, or is a message that may help to educate people about the work that you're trying to do, you can download these from the AIDSview website, and you're free to share them in your educational efforts. So a few key insights from our analysis is that Black people in the United States represented 14% of PrEP users, but 42% of new HIV diagnoses. We would like to see the PrEP use among Black people be proportionate to the share of new HIV diagnoses. Similarly, Hispanic Latinx people represented 17% of PrEP users, but 27% of new HIV diagnoses. And conversely, white people accounted for only 26% of the new HIV diagnoses, but for 65% of the PrEP use. This is just another way to express the PrEP to need ratio concept that I was showing you before. And regionally, if we look in the South, where Black people made up over half of new HIV diagnoses in the South, Black people accounted for only about 1 in 5 PrEP users in the South. In the Midwest, Black people made up 48% of new HIV diagnoses, but only 12% of PrEP users. In the West, Hispanic Latinx people represented 43% of new HIV diagnoses, but only 22% of all PrEP users. And so I think there is some good news here, which is that PrEP use has really increased steadily every year since 2012. I will note that if you look at sort of year-over-year increases, we do notice that in 2020, the increase relative to 2019 was only 11%. So it's a little bit slower pace of growth during that year when we had a heavy impact of the COVID-19 epidemic. Overall, the South accounted for 52% of HIV diagnoses, but only 39% of PrEP users. And we also know that there are some things that are associated with sort of higher levels of PrEP use and more equitable PrEP use. So in 2021, for example, states that had expanded their Medicaid programs had rates of PrEP use that were 1.5 times higher compared to states that did not expand Medicaid. Among all PrEP users in the US, 92% were male and only 8% were female, despite the fact that women comprise 18% of new HIV diagnoses. So again, there's another sort of equity gap there. And teenagers and young adults, those aged 13 to 24, had the greatest unmet need for PrEP among all age groups, with a PNR of 6, and these younger people accounting for 20% of new HIV diagnoses, but only 13% of PrEP users. So I mentioned before that there are limitations to the data. I think it's always important to acknowledge these, and I also think it's a fine line to walk between saying, we want to be rigorous in our use of data, but we also want to use data that we have access to develop hypotheses, to identify areas of concern, and here the major issue or limitation of the data, that there's substantial amounts of missing race data in the commercial pharmacy data. And the thing that we focused on in this analysis was to ask whether the missingness was different by region, which was the level of the analysis that we were conducting here. And we found that missingness did not vary substantially by region. This is clearly something that we need to work on, and that may include developing better methods, thinking about imputation, thinking about alternative data sources to try to correlate. In the meantime, we've used these data, we've checked for differential missingness by region, and we're noting this as an important limitation. Also, I want to emphasize that PrEP to need ratio really is an equity metric. There's no target level of PrEP to need ratio that we can say if we reach that, then we're going to end the epidemic. Or really our analysis doesn't directly address the levels of PrEP use that would be required to achieve targets of reducing incidence. This consideration of the data is really about equity and about whether we're serving the communities and the people who are at highest risk for HIV with our PrEP programs. And we also recognize that our PNR calculations might be impacted by some kinds of information biases like underreporting of HIV diagnoses, or if our algorithm misclassifies the pharmacy data for PrEP indications, those could result in biased estimates of PNR. So in conclusion, we're advocating that PrEP programs should really be guided by PrEP equity. That's this idea of use relative to the epidemic impact, and not solely by PrEP equality. PrEP equality would say we want to get equal use in all groups, regardless of how the HIV epidemic impacts that group, that region, that racial ethnic group, that sex. So our argument is that PrEP equity is critical to evaluate PrEP programs. If we use that measure, U.S. prevention programs in all regions actually demonstrated decreasing PrEP equity over time. Those stair-stepping, progressively larger gaps between the red and yellow lines for Black and Hispanic PrEP to need ratio and the increasing purple line for white residents in those regions. Among the U.S. regions, the U.S. South lagged all regions in equitable PrEP use, had the lowest PNR compared to other regions. And we need better programs to provide PrEP to communities and people at greatest risk for HIV infection. I want to point out that an ecological study that was led by Aaron Siegler, who you hear from shortly, demonstrated that the PNR was higher, on this scale of equitable PrEP use, more equitable in states that have PrEP programs or Medicaid expansion programs or both. And so we advocate that states that have not yet expanded Medicaid need to consider doing so, and that states that don't have PrEP drug assistance programs need to look at whether there are ways for the state to fill in gaps in the series of resources that are needed for someone to get on and stay on PrEP. We recommend that PrEP equity metrics may be a more meaningful way to assess the impact of PrEP programs rather than just counts of PrEP users, and the PrEP equity metrics should be assessed and reported routinely in monitoring PrEP programs. And finally, we need additional research on the extent to which different interventions or policies impact PrEP equity. We have a large pipeline now of interventions to increase PrEP use, appropriate PrEP use, and I think that's great. But when we evaluate them, we should evaluate not only whether they increase the use of PrEP, but whether it's increasing the use of PrEP in the people at highest need. If we don't do this and we don't ask this question about our interventions, then we run the risk of increasing the number of PrEP users while continuing to decrease PrEP equity, which is what we've been seeing for the last 10 years. So I'll talk now just a bit about the PrEP data that are available on AIDSview. You can see these mapped, you can download data. We've long had the goal of adding PrEP use data by race ethnicity to better understand the inequities that are inherent in our HIV prevention programs. So we're working to have race ethnicity data available at each level, where it's available and when it's available. So you can see there's a graph here that has city, state, and county level HIV prevalence and new diagnoses, mortality, HIV testing currently only at the state level. And right now, we're only showing PrEP use at the state level. I think because of this issue, particularly of missingness of race, we want to be certain that we understand. I think the finer the geographic level you get to, the more risk you have of some bias creeping into those estimates. So we'll continue to do methodologic work with colleagues, some of whom are on this call, about how to understand race ethnicity data around PrEP use better. The new state PrEP use by race ethnicity maps can be found on AIDSview, and it's highlighted here where to go to find those under the overlays, and I encourage you to check them out. We've also updated our PrEP county level data for 2020 and 2021. And finally, just to point out that there are a lot of different places within AIDSview where you can find data beyond our maps. And one thing, if you haven't checked out your local profile page, I would encourage you to do that. That may be at the state level or at the city level. And there are also national and regional profiles if you're trying to grab that piece of data for a grant application, or to depict the impact of HIV or the extent of PrEP use in your region or your state. You can go to find those. And particularly, I encourage you to check out some of the new PrEP use and PNR data on the state profile pages. Here are some examples of that, but you can actually go on and see some of the data. If you looked at these data that we presented at the census level and said, I wonder how that looks, in my state, where the data are available and stable, you can see those on your state profile pages as well. We also have a series of deep dives on AIDSview that we call Deeper Looks. There's an excellent one on PrEP use that gives an overall view of the PrEP use data on the website, so you can check that out. And then, as you've seen throughout the presentation, we like to create infographics to make these data more accessible to everyone. Not everyone wants to look at a big table of data and try and eyeball the trend. So these really break this down into smaller pieces of data and illustrate them in a more way with more sort of graphics and some bulleted messages. You may use these to learn something on a topic that you're interested in, or you may want to use these to educate some of the groups that you work with. And finally, we conduct what we call AIDSview Q&As throughout the year. These are conversations with experts to get their unique perspectives on the data we're presenting. I'm just sharing a few of them here. Folks like Leisha McKinley-Beach, like Leandro Mena, talking about these data and their perspectives on them are very great opportunities to sort of learn from how they're reacting to these data. So I encourage you to go and check those out on our news and updates page. So now I'm going to turn things over to a group of colleagues that I just couldn't think more highly of, and people who really have been moving forward this agenda around PrEP equity, PrEP accessibility, clinical guidelines, how we measure, how we move. And so no one better to join in a discussion of these data than Dr. Dawn Smith and Dr. Amanda Castell, and Dr. Aaron Siegler will serve as a moderator. Also someone, as you can see by the use of the PrEP to need ratio that he created, who's really shaping our discussion about this. So I'm going to turn things over to Dr. Siegler, Dr. Smith, and Dr. Castell with my thanks for being our opportunity to talk about these data and to hear your perspectives. Aaron, over to you.
Great. Well, thank you very much. Excellent talk. And so I am going to please keep sending questions through the chat function, and we'll try to get to them either written or verbal responses, but love to just kick it off with our panel. And start with Dr. Castell. What do you think is the most important or surprising finding from these data?
Thanks, Aaron, and Patrick and the AIDSview team for having me. We have been waiting a long time to see these data broken down by race, ethnicity, certainly at the state level. And, honestly, I would say that based on some of the prior data that we had available to us, certainly from a local standpoint here in Washington, D.C., and then also just clinically seeing the people that were availing themselves of PrEP. I think that these data are really aligned with what we'd seen otherwise, but certainly, there's a difference between having it anecdotally and actually having the data in hand. It's a little bit sobering to see the huge inequities and the growing gaps in inequity. Are certainly disturbing. The lower rates among African Americans, also among women and adolescents, are also of some particular concern. And I would be anxious, and I guess we'll talk about this a little bit later, but to also have these data contextualized somewhat like you did, Aaron, with one of your prior analyses where you were able to look at PrEP use in the context of Medicaid data and PrEP-DAP programs. I think that that will help us to really fully interpret why we're seeing these inequities.
Great, thanks. And Dr. Smith, do you have thoughts about what's surprising or important about these data? You are on mute.
I think that these data are important because so much of the HIV epidemic is built on inequities. No matter what HIV parameter you look at, you see these same racial and ethnic inequities. And they've been around since the beginning of the epidemic. So I think understanding where we are with these inequities for PrEP use is really critical to making it work for the populations that it needs to work for. I would say that I'm surprised only that people are surprised by the inequity, because this is not new news. We have known this about PrEP and about HIV for many years. And so I guess I'm a little surprised that everybody kind of went, oh my God, there's disparities, there's inequities in PrEP use.
Sorry, I'm mute. Yes, it's surprising that people are surprised. It's a continuing theme. I think the magnitude is surprising. The fact that the gaps are increasing is both, a really important theme for us to, know that the direction we're going is not in the right, it's not sufficient. The programs that we've done, the pieces that we've tried to put in place are not sufficient to cover that gap or start to shift that trend yet. And so more efforts are needed. So, AIDS-VUE data are used by many different categories of professionals, public health professionals, policymakers, advocates, and researchers, and even people impacted by HIV. And how do each of you see some of these new PrEP data being used?
Amanda?
Sure, I'm
Take
happy
it
to
away.
start. So yeah, I think that Don and I are like-minded in this. So I do think it's important to have the data, right? I don't want to discount it. I think, like I said, it's filling a longstanding gap, and it helps to further the argument that there are these huge inequities. I think it also should hopefully spur people to say, what are we doing that's working and what are we doing that's not working, right? How do we figure out how to effectively scale up PrEP use across a diversity of settings? Now, obviously, we're only looking at the state level right now, but hopefully eventually we'll have data at the county level as well to really understand which programs are there, which ones are not. I think at this point in time, with the data that we have, as you mentioned, Aaron, there is a large role for advocacy here, right? To go to your local government, to go to your state government, to go to Congress with this information in hand and say, we really need to advocate for more funding to be able to have, whether it be telehealth programs for PrEP, or to have Medicaid expansion that will cover PrEP, or from somebody like my perspective, from a clinical standpoint, to think about what types of programs we can use that maybe aren't clinic-based, but that can get out into the communities or get information out into the communities. And then also from a research standpoint to figure out, what other additional data do we need to really be able to triangulate the PrEP data, the race ethnicity data, to further understand where we are. I'm sure Don will talk about this, but lastly, I would just say, of course, to be able to use the data in a way to monitor progress and evaluate programs. And of course, to look at benchmarking things like our ending the HIV epidemic goals in terms of PrEP uptake.
Yeah, I completely agree. I think that there are a number of resources. AIDSview is one. The AHEAD dashboard has similar data on it. CDC has a website called Atlas Plus, where you can download all kinds of HIV and STD data down to the county level for a variety of uses. So I think, we understand that without being able to demonstrate to people what the problem is using data, we're not going to be as successful as we could be at redirecting programs to address these gaps. I think, for example, one of the things is that we may have in mind an overall goal for PrEP use. We may say we want, 50% or 70% of persons who should be using PrEP to be offered PrEP and use it, right? But if we do that across the whole population, that doesn't address the disparities issue. And it may be that we need 80% of one population and 40% of another population. And only when we can monitor how we're doing in each population relative to their HIV diagnoses can we really say that we have focused the efforts on PrEP in a way that will not just increase overall use, but that will reduce these racial and ethnic disparities. And I think you're right. There's similar data about women's low use of PrEP. And I think it's also an issue in terms of monitoring what's going on with women's use of PrEP.
Erin,
Go ahead.
I was just going to add, because, I think one of the things that we talk about with the AIDSview data is really getting to a granular level. And so that's where, being able to look at what is happening with women, right? And the context in which they are getting access to PrEP, how does that differ than, say, a child who's a minor, right? I mean, there's the context in getting access to PrEP is so different compared to a man, or, again, of course, bringing in all of the racial ethnic differences as well. So I think that it's just really important to be able to get down to that detailed level and to think about, as Don was alluding to, yes, we need to think about the population as a whole, but then we need to think about these smaller populations and the context in which care is delivered around HIV prevention, and then how do we address that in a holistic and appropriate manner.
Right. And I think these data, they represent the start of a discussion, not the end of it, which is exactly what you're getting at, Amanda, that the data allow us to say, we see an inequity here. We're seeing this thing locally, low uptake among women, and it's probably something we know nationally, but when we know it locally, then we know that there's something, it empowers like local officials to think about action, but then it's not the end of the question, right? Because then we have to think about how the exact mechanisms people are accessing PrEP and how we can, in public health, minimize barriers to access, very systematically and carefully. So, we are getting to the 10th anniversary of PrEP being approved. We're at it, I guess. And, how can these data help us as, public health experts and officials improve our resource allocation to try to help PrEP reaching communities with the greatest unmet need? And I'm just going to throw in a little pitch that I think both getting PrEP to the communities at greatest need, it increases the cost effectiveness of the intervention, and it achieves health equity, because you can't address the epidemic without addressing people who are most impacted.
Go ahead, Don.
I'm not sure what the question is
So
there.
So the question is, how do these data inform allocation efforts? Do they inform allocation efforts? How should they be used to inform allocation efforts?
Well, I would say that they haven't been used in that way. enough. And so hopefully the presentation of this data and the dissemination of this information will cause people to look closely at what's going on in their jurisdiction and what that may mean for their programs. One thing I would say is that, Patrick pointed out that that the missingness was not different by region. It is significantly different by state. And so even though AIDSView is presenting the data at the state level with a simple imputation method, I think, again, that's a starting place. And as he said, there's work going on to figure out if there's better ways, more robust ways to validate those state numbers. And I think that also affects, I know some people want to see the data at the county level, and that's an even further level where we're very unsure about how to use what race ethnicity data is there in a valid way. So I think you sort of need to stay tuned for those things, and we'll see more. But I think if you I think that there's enough data there for any jurisdiction to be able to make some estimation of what's going on in their jurisdiction. I think both certainly on the CDC website, Atlas Plus, and I think on your website as well now, there may be PrEP numbers at the county level, but they won't necessarily be stratified by race ethnicity. So again, I think there are ways in which anybody can use some of this data to try to understand what's going on in their jurisdiction and what that means for their programs. And I think some of the work you've done, Erin, looking at the relationship between geography and access to some of these services, I think is also important, in that as you get down to the lower levels, you can look at where are the services provided and where are the people who need the services, and do I have my clinic in the right place, or do I have my outreach in the right place? And now we should be able to look at that, not just for the overall population, but for some of these important subgroups.
Great, thank you. Yeah, and for those interested, there's a publication on PrEP deserts, an area of low density of PrEP providers, but we've also done some analyses by cities and within cities, and found that PrEP providers are often not located nearest the populations with highest incidence PrEP clinics. Sorry. So real quick, an anonymous attendee said Amanda mentioned looking at more PrEP data in the context of Medicaid and states. PrEP-DAP, are there existing data resources that examine PrEP use within these programs, particularly PrEP-DAP programs? So I think, I'm not sure about state level PrEP-DAP programs. I know that New York State has a fair amount of data in their dashboard on PrEP-DAPs. Our analysis that I led, and along with Patrick and others on the AIDSView team, we demonstrated that PrEP-DAPs were associated with a 99% increase in PrEP use. So it's kind of a cross-sectional design. So we're looking to do a bit more digging to validate that relationship. But I do think that there's a very strong association between provision of drug access programs at the state level and PrEP use in those states. So certainly promising early data. And I think there are some other more local research that has shown associations between the creation of PrEP-DAP programs and PrEP uptake. Wakefield asked an interesting question of our panel. So what do we know about newly diagnosed persons and their relationship to PrEP? For example, have they started using PrEP and discontinued? Are there specific social determinants that impact PrEP in a hierarchical way? Is there an impact of consumer-directed CAB that may impact these differences? So I'll let you guys, whichever one of you wants to take that. Bunch of questions there, but they're all interesting. So
I'm not sure I can answer all of them, but that was certainly in thinking about the presentation. You know, we saw this disruption, right? This slower pace of increase during COVID-19, right? And so it makes me wonder, you know, well, I'm not wondering, but we know COVID disrupted access to HIV prevention services. It certainly would be interesting to see if that pace was consistent as you break it down by state. And I always like to kind of be glass half full and think about, well, what did kind of the higher achievers or the areas where there was less inequity, like what did they do to be able to overcome that and to make sure that services continue to be available, et cetera? Those might be some lessons that we can learn somewhere else and apply somewhere else. In terms of newly diagnosed people and their relationship to PrEP, we are certainly looking at that here locally in DC. And I know that we have done other AIDSview analyses led by one of our doctoral students, Farah Mohana, who was able to look at things like PrEP discontinuation and PrEP persistence. And so I do think that that's a great question, Wakefield, and something that we could actually endeavor to look at with these new data and stratified by race and ethnicity.
I think there are several studies showing, looking at that from both directions. So there are studies showing that in cohorts of people who start on PrEP, first of all, that many people stop and start, and many people stop altogether after 6 or 9 months. And that the rate of infection in the months following stopping PrEP goes right back up to where it was before they were on PrEP. There have been studies looking at the other direction and saying, of all the people newly diagnosed with HIV, how many have a history of taking PrEP in the previous few months? And it shows that many of them, in fact, do in recent years. So I think we know that we spent a lot of time early on in the epidemic worrying about getting that first pill into people's mouths, getting uptake where it wanted to be. And now we realize that actually continuity of PrEP is what we need to be working on, that it's really more about helping people identify the barriers to staying in PrEP care and for as long as they need it, so that they don't become infected. The other thing, the other point I would make is that sometimes I think this data will be very useful to us to understand how interventions are working for different populations. Sometimes we make assumptions that, you know, okay, so COVID was a problem. We instituted telemedicine. Telemedicine will be wonderful, and it will be especially good for people who are in rural areas or people who even are in urban areas but don't feel comfortable going to the clinic. So maybe it'll help reduce disparities. We don't have any evidence of that. And in the few studies that have looked at it, it had no impact on disparities. So I think we do need to be creative and try new things, but I think we need to make sure that what we're trying is working for the populations that need it to work the most.
I think that's a fantastic point. And, you know, just to put us in present day, we're still dealing with COVID and, you know, issues around vaccine rollout and certainly monkeypox. And, you know, all of these issues are related to how do we create these programs in a fair and equitable manner to make sure that they're getting to the populations most in need. Absolutely.
great. Just a different part of that question I think is really critical. I mean, what are the structural things that we can do to help improve? You know, are there structural interventions? Are there structural changes to how people access PrEP that either of you think are promising ways to think about addressing, you know, race, ethnicity, whether it's specific programs that can be brought to scale or specific policies that are important? What do you think are the most promising things that are coming down the pipeline.
I actually think specifically for racial and ethnic populations that there are not a lot of things that are designed to figure out what works best for those populations. There are lots of studies about let's try a new thing here or there, but they tend to be, we'll take all comers and we'll try to enroll enough Blacks and Hispanics that we can do a sub-analysis. But to the extent that Black and Hispanic people may have specific barriers, they may need specific interventions. And there are very few that are targeted specifically in that way. One of the most ambitious is the new HPTN 096 study, which is trying multiple methods to get young Black men in the South engaged in PrEP care. And I think HPTN has done other studies that were focused similarly on the Black MSM population. But I don't think that we have good program models for what works for Black women, for example. People have tried a few things. None of them has been really as successful as they wanted it to be. So I think we're still trying to figure that out, Erin.
Yeah, I agree. Just, again, thinking from my local perspective and my own research, right? We're trying different things, but I'm not sure that they are, well, I know that they're not tailored towards a certain race or ethnicity to really try to, or power to even be able to answer that question and scale that up. They may be innovative, but they might still be reaching the same populations in the end.
Great, thank you. I have a question from Claudia Ordonez. I think we'll email you. We'll have Dr. Smith email you that information so that you and others can access it. So, what kind of insights are we getting from some of the more granular data that we might not get from overall data? Can either of you speak to certain insights that we're seeing in the hyper local data or the more local data, like state level data, that we might not see in the national data, or we might see?
I mean, I think we talked about it a little bit earlier, but certainly the ability to triangulate, to be able to look at the region, to look at sex and gender and race ethnicity, that ability to kind of put all of that information together really helps us contextualize the data, versus just looking across, the state and saying X proportion of people have started PrEP or the rate is increasing. So anytime we can add another layer of information, I think is useful. I think it was Wakefield who was asking about, adding some of the social determinants of health would certainly be helpful in terms of getting to another level of granularity in our interpretation of what we're seeing.
I don't have anything to add. That's great. I agree completely.
Great, awesome. All right, and other ones, it does seem like there's a lot of interest in like telehealth as a potential fix. There's a couple comments as to telehealth, but it may not serve predominantly white MSM. This is an issue close to my heart because I have 2 clinical trials looking at whether telehealth, teleprep improves retention and care and both studies have over samples of African-American participants to allow us to look at whether that addresses for that demographic as well. And so I think, these are probably different questions, right? That the one question is, does this, are programs mainly reaching white MSM? And the other is, if the programs reach the right people, could they improve retention and care? And what would those look like? So we actually just finished collecting data for the Adolescent Trials Network study on that. And so that trial data collection is actually closed out. So we'll be analyzing those data next couple months, and those will be released shortly. And then we have a similar trial with a few differences for adults that we'll be looking at as well. So those data are coming still. But how do we make telehealth services more available at the program level to Black MSM, Latino MSM? What are the things we need to do to change the telehealth model to open up access?
Can I change the question a little bit?
Go for it.
To what do we need to do with alternative delivery venues, of which telehealth is one? And I think we have to start with the presumption that the same inequities, the same systematic inequities that are interfering with healthcare for Black and Hispanic populations are going to interfere with any of these alternative venues. For example, in addition to telehealth, people frequently say, well, we'll put it in pharmacies, right? Because now Kroger and CVS and Walmart, all these different pharmacies now have clinical services in or near their pharmacies. And that would be, that would be a close by place. It would be a non-stigmatizing place to get PrEP. Except just as you found PrEP deserts, there's a literature on pharmacy deserts. Where pharmacies are, and particularly where pharmacy clinics are, is not in inner city African American and Hispanic communities. I would think that with teleprep, one of the issues is going to be, how do you make people aware of it? And for whatever reason, our current communications channels are really focused on white MSM. And they're the people who are going to a telehealth channel and logging on and signing up for telemedicine. So trying to figure out, how Black and Hispanic populations use web-based services first, and then figure out how do we build a telehealth program that adapts to that, to the way that they use online services. And so I haven't seen that proposal yet. Is that your next proposal, Erin?
That'll be my next one. Yeah, no, I agree. Patient-centered care models are the way we need to go. We need to meet people the way they're interacting with their environment and their world, and make it and that just lowers the barriers to getting preventive care, which is, really the name of the game for public health. So couldn't agree more. Lisa Pointer has an amazing question that is just stellar. And it's a question, comment, and just, something needs to change in messaging because Black women's numbers are too high. And, I completely agree. I think that's a really critical point, that the way we think about communicating PrEP, it's very risk centric, and people don't understand their risk perfectly. And it's not based on a kind of preventive care model that I think is sustainable. That like a continued high perceived risk may not be sustainable. So I know there's some programs that have been proposed in South Africa that actually rename PrEP to be like a much more culturally fun and acceptable thing. So I think there are some efforts internationally to kind of reframe this, and providers like you, Lisa, will hopefully we can help think through next steps to reframe and help people understand the relevance of PrEP to their lives.
Aaron,
I
just,
really, oh, go ahead, Amanda.
no, I just wanted to say one thing because I think we're talking about programs, but I also still think that there's a lot of education that needs to happen, whether it is, helping people, particularly Black women, figure out what their risks are based on Lisa's example, right? I mean, there's a disconnect between somebody's risk perception and whether or not they really should be availing themselves of PrEP, and getting the information out as to the fact that this is available and is something that you might consider, I think is just as important as figuring out how to then get the services to people, because we could get the services out there, but if people don't know that it's for them or that they need it, then that's kind of also a wasted effort. So I really think the two have to go hand in hand.
Perfect. Okay. There are a couple more excellent questions, but we are fully out of time and past a bit. So I want to thank everyone today for their questions. Please feel free to email us if you guys have any more. In the meantime, we will try to address via email to the individuals who asked these great questions and try to answer them. I want to thank the panelists today, Dr. Smith and Castell, and thank Dr. Sullivan for his excellent presentation. And thank each of you for your time today. Please do stay in touch, and we look forward to our next meeting. Take care.